Hopefully everybody can hear me and see the slides okay. My name is Mark Wine. I'm an endocrinologist at Mass General in the calcium and metabolic bone practice. And today we're going to be having a discussion, a case-based workshop with some cases related to calcium and mineral metabolism disorders. So hopefully that's where you all want to be, because that's what we'll be talking about for the next hour or so. Please, if questions come up, feel free to raise them. I think probably the Q&A function is the best. Although I think in this Zoom format, it also may be possible just to raise your hand or speak up. I would love this to be interactive and hear about the challenging cases that you all have, especially as stimulated by the cases that we review here. So probably most people who are here want to be here. Let me see, there's something in the chat already. It says I can hear and see your presentation. Excellent. All right, so we'll get started. And again, don't be shy. I think we have kind of a nice sized group so this could be interactive. All right, and I guess I would say if you're not speaking, try to put your thing on mute, just because background noise can sometimes come up. All right, so we have three cases to go over, and I'll get started with the first case, and hopefully all of these kind of bring up different points related to calcium and mineral metabolism management, and definitely we want this to be kind of clinically oriented as a case-based workshop. So first, we're going to start with considering a 56-year-old woman who's referred to us for hyperparathyroidism. Her medical history is notable for going through menopause at age 48. Notably, she had morbid obesity with a BMI of 45 and underwent bariatric surgery with the Roux-en-Y gastric bypass at age 54. There was no history of any fractures or of any kidney stones. Her medications are listed here. She's taking calcium carbonate, 600 milligrams twice a day. She's taking vitamin D, 400 international units once a day, and a multivitamin, which also has a decent amount of calcium and vitamin D. Here is her physical exam. She appears well. Her BMI is down quite a bit at 33 from 45 before her bariatric surgery. Her Schwastik and Trousseau signs are negative, and there's no neck masses. So I said she's referred to us for hyperparathyroidism. So what about the other labs? So here you can see her levels of calcium, which is in the normal range for our lab, her albumin, which is slightly low, but still in the normal range for our lab, her phosphorus, which is 2.1, which is in the normal range for our lab. Her parathyroid hormone is elevated. This was a referral for hyperparathyroidism at 134, with our reference range going up to 60. Her vitamin D, 25 hydroxyvitamin D is 22. And not shown here, but important for the case, is her kidney function. Her BUN and creatinine are both within the normal range. And a 24-hour urine is performed, which has about a gram of creatinine and a calcium of 36 milligrams. So now we have a patient who has hyperparathyroidism with normal calcium, and we need to figure out what's going on. So in terms of thinking about this, the etiology of this patient's hyperparathyroidism, several options are listed here. Could the hyperparathyroidism be due to vitamin D deficiency? Could this be due to malabsorption of calcium following her bariatric surgery? Could this be due to an inability to solubilize the carbonate-based calcium supplement that she's taking after bariatric surgery? Or could this be kind of due to all of the above? And often when we have a all of the above question, that it kind of illustrates that the hyperparathyroidism in this patient may be multifactorial. And so we're going to kind of talk a bit about secondary hyperparathyroidism, which this is, and how this is kind of an increasing problem in the population of patients who are undergoing bariatric surgery. So first of all, I think it's important just to review, and this may be very simple, but just to make sure everybody's kind of on the same page, why we think this is secondary hyperparathyroidism and not primary hyperparathyroidism. So when I teach medical students or our internal medicine residents, we kind of go over a relatively simple differential for secondary hyperparathyroidism, which is of course high PTH in the setting of a normal or low normal calcium. And I think there are three major causes of secondary hyperparathyroidism, which are listed here. So obviously vitamin D deficiency can cause secondary hyperparathyroidism. If you don't have enough vitamin D, the gut can't absorb calcium. And so the parathyroid gland kind of constantly senses a negative calcium balance. Elevates PTH, and obviously the calcium has to come from somewhere, and so that thins bones over time. Likewise, if enough calcium is not coming in through the diet or being absorbed by the gut, that can lead to secondary hyperparathyroidism. So commonly, in patients after bariatric surgery, this is an issue. Obviously, after a gastrectomy, stomach acid is not present, and so acid is needed, obviously, to solubilize a carbonate-based calcium supplement. So patients after bariatric surgery really do need a citrate-based calcium supplement, which does not require stomach acid. And then, of course, you can have some patients who just aren't consuming calcium at all. Patients who follow a vegan diet, don't take vitamins, things like that. Not relevant to this case, but I think relevant to many patients that we'll come across with secondary hyperparathyroidism is the fact that chronic kidney disease can cause secondary hyperparathyroidism, multifactorial there, but one issue is that the kidney is needed to activate vitamin D. So in the setting of chronic kidney disease, where kind of nephron mass is reduced, you're not able to 1-alpha hydroxylate vitamin D. And so low 125D levels stimulate PTH secretion. Furthermore, high phosphate levels due to inability to excrete the filtered phosphate directly stimulate PTH secretion by the parathyroid gland. So there are multiple mechanisms where chronic kidney disease can cause secondary hyperparathyroidism. And of course, this is a course for endocrinologists, so we kind of go beyond the common forms of secondary hyperparathyroidism. And so I think we also want to appreciate that hypomagnesemia can lead to defects in PTH signaling. So sometimes there could be hyperparathyroidism because of low magnesium levels. You could have kind of an idiopathic hypercalciuria due to a renal calcium leak, which is kind of in the more rare causes of secondary hyperparathyroidism, but definitely something that should be considered and obviously has been ruled out here with the 24-hour urine measurement, which showed hypocalciuria and not hypercalciuria. Of course, the anti-resorptive medications that we use for osteoporosis, especially the potent ones like denosumab and intravenous bisphosphonates, basically block the skeletal actions of PTH. So if you have a patient who has kind of a insufficient calcium intake or secondary kidney disease, sometimes you can really see PTH levels go up quite a bit after denosumab treatment. And so that's kind of a common thing that we can sometimes see in our osteoporosis patients on these potent anti-resorptive medications. And then finally on this differential is this somewhat confusing and controversial entity of normocalcemic primary hyperparathyroidism. In this instance, usually the calcium levels are at the very top of the normal range, and usually the urine calcium levels are quite elevated. And so, some people think that normal calcemic primary hyperparathyroidism is kind of a small parathyroid adenoma before it kind of grows up enough and makes enough PTH to cause hypercalcemia. But certainly something that should be in the differential when you see hyperparathyroidism. But, I think in this instance, when our blood calcium is at the lower half of the normal range and the urine calcium is quite low, I think normal calcemic primary hyperparathyroidism is quite unlikely. So hopefully this differential kind of sticks with you, because I think this is a useful framework in general for thinking about patients with secondary hyperparathyroidism.
God, I'm tired and hungry.
Okay, so now kind of moving on in this case, we have this patient who had Roux-en-Y gastric bypass with what looks like a high calcium intake and not that terrible vitamin D level of 22. So why is her urine calcium low, and what can we do to normalize her PTH? Well, I think hopefully the discussion that we just had about causes of secondary hyperparathyroidism is informative here. So I think the hypocalciuria that we're seeing is due to kind of insufficient absorption of the calcium. So even though she's consuming what looks like a good amount of calcium carbonate without stomach acid and without a stomach, essentially, the that medication is not being absorbed. And so the amount of calcium coming into her system is low, and the PTH obviously promotes calcium reabsorption in the distal tubule. So this hypocalciuria is basically the kidney's effort to hold on to everything that comes its way in order to keep the blood calcium levels in the normal range. And so what with the management here, I think would be relatively straightforward. I think the first thing to do would be to switch her over to a citrate-based calcium supplement. I typically use calcium citrate, 800 milligrams or so, 3 times a day with meals, and it is better absorbed along with dietary intake. And if I think it would be ideal to see these patients 25 vitamin D, hydroxy vitamin D up above 30. And so that would be the first thing I would do, and probably wait about 6 months before repeating labs, just because of the setting of longstanding secondary hyperparathyroidism. It can be challenging it can be slow, I should say, for the PTH levels to come down. And so I would kind of change from calcium carbonate to citrate, boost the 25 vitamin D levels, and repeat labs kind of in about 6 months. Um, yeah, I think another very important consideration in patients who have had bariatric surgery with or without secondary hyperparathyroidism is bone health. And so appropriately, because of her secondary hyperparathyroidism, a bone density was obtained with numbers here. So as you can see, the bone density isn't that bad, but it's going down. Our T-scores are kind of only in the mild osteopenia range, but if you look to see kind of what's happened over the past couple of years, an 8% decrease in the hip and a 4% decrease in the spine is certainly more than you would expect for a typical kind of perimenopausal woman, where bone loss is typically more in the kind of one-ish% loss per year. And so this kind of opens up a number of interesting and important questions that we could consider. I think there are important questions about the effects of secondary hyperparathyroidism deficiency. I'm sorry, is there a question? Oh. A question is about secondary hyperparathyroidism and vitamin D deficiency on bone density. What about the effects of bariatric surgery itself on bone density? And then we wonder, is this decrease that we're seeing of, kind of clinical importance to the patient beyond the numbers on her bone density test? Okay, great. So I see a question in the Q&A, which I'll come back to after this case, because it looks like it's kind of a general question that isn't relevant to a general question. Okay, so yeah, as I mentioned, this woman is 54 years old, so she's kind of in that perimenopausal period. And so I think a useful kind of thing to review in this setting is kind of what to expect in terms of bone loss during the perimenopausal period. And so thankfully, we have a great amount of, clinical data addressing bone density changes in women across the nation of different races and ethnicities during this time. And what you can see here in both in the spine and in the femoral neck is that bone density typically is stable in, the top before menopause, but during that kind of early menopausal transition, there is kind of an accelerated bone loss compared to what we see in older women who lose about 1% per year, whereas, in the spine, about 2.5% per year, and in the femoral neck, about 1.75% per year is lost. And so there is some accelerated bone loss that occurs in all women with or without secondary hyperparathyroidism during this time. However, what we saw in this patient of 8% over 2 years of the spine is certainly greater than what would be expected from just the perimenopausal transition alone. And so, what could be explaining this accelerated bone loss that we're seeing in our patient? Well, certainly the secondary hyperparathyroidism is contributing. And in addition to that, there's a large amount of high quality data that's emerged in the past 10 years or so that bone loss is accelerated due to bariatric surgery, and specifically the Roux-en-Y, even compared to the sleeve gastrectomy. This is like a really interesting area where I think the clinical observations are quite clear. This is independent of secondary hyperparathyroidism, which does develop in some patients after bariatric surgery. But even without secondary hyperparathyroidism, bone loss following Roux-en-Y gastric bypass occurs at an accelerated rate. And, I think the jury is still out with respect to the mechanism of that bone loss that occurs. I think there are ideas that they're kind of gut-derived factors that affect the brain and affect bone. And this is definitely kind of an exciting and important area of research. And the reason that I think this is an important area of research is that the bone loss that occurs after bariatric surgery translates to an increase in fracture risk. Initially, when these observations were made, people said, well, patients who have bariatric surgery are starting out, with obesity, and so their bone density might be a little bit high. And so you're going from high to, a little bit less high. So maybe this isn't a big deal. But without a doubt, this is associated with an increase in fracture risk. This is a slide that was provided to me courtesy of my colleague, Elaine Yu, who spoke, I think, a couple days ago in the Calcium Day, who has really been one of the leading researchers in this field, looking at the effects of bariatric surgery on bone health. And even compared to patients who have other forms of bariatric surgery, like sleeve gastrectomies and adjustable banding, patients who undergo Roux-en-Y have a significantly increased risk of all kinds of fractures, vertebral compression fractures, hip fractures, forearm fractures. So, I think this is something that we should be paying attention to. And, currently there are very exciting intervention studies going on to ask whether anti-resorptive therapy at the time of bariatric surgery may help preserve bone density and even reduce fracture risk. Okay, so that is kind of everything that I wanted to say about bone health and secondary hyperparathyroidism in the bariatric surgery population. There is a question in the chat about another patient. So I think I'll take this question before going on to the next case. And please, if you have other questions about what we just covered or any other cases that you'd like to discuss, feel free to throw those into the Q&A, and we can discuss those. So I'm going to read the question because I haven't yet. It says, an 82-year-old woman with osteoporosis causing multiple vertebral fractures started on teriparatide with Prolia for 2 years. Fracture stopped, and after 2 years has continued on Prolia. Since the past 1 year, has had 2 fractures, fragility, hip, wrist, minimal trauma. What do you recommend? Next, her GFR is 30, did not do well with alendronate in the past, with bad myalgias. This is a very challenging clinical situation, and I think it highlights, let's say something very not helpful first, which is that, what this highlights is that the current therapies that we have are really not sufficient to cure osteoporosis. This patient has been treated really with perhaps the most aggressive, osteoporosis medications that you can imagine. The combination of teriparatide and denosumab, and then
I'm leaving to go to them.
so, I think there isn't really much more that you could think about doing. I would have a very high threshold to think about, going back to another round of bone anabolic therapy because, it may be that, yeah, that's the question. Would you try another year of teriparatide? I think you would want to do that with the denosumab on board. But, I would imagine that with her GFR of 30, she may have some secondary hyperparathyroidism and, the utility of PTH therapy for a patient with secondary hyperparathyroidism is kind of questionable and not super solid. Thinking about using romosozumab or Avinity, here I would have a pretty high threshold. You worry about with her CKD, her risk of cardiovascular events. So I think I would just be as careful as possible about looking for secondary causes of this kind of denosumab failure. Or if they're existing, vitamin D deficiency, thyroid disease, is your secondary hyperparathyroidism relatively well controlled? Is your CTX fully suppressed on the denosumab? Because if it isn't, then perhaps more frequent denosumab therapy. But generally, using PTH-based therapy for patients who have secondary hyperparathyroidism from CKD is, not, it's hard to know how effective that's going to be. So I think this just kind of highlights the challenge here. Another question has come up, which I'll take before going on to the next case, which is, do you routinely perform genetic tests on young individuals, say under 30, with primary hyperparathyroidism? I certainly think carefully about MEN1 and other forms of familial hyperparathyroidism in young individuals who present. I think epidemiologically, the data, because those forms of primary hyperparathyroidism is so rare, it's still more likely that it's just a sporadic parathyroid adenoma. But for patients, in my experience, usually under 40, with primary hyperparathyroidism, I'll certainly send prolactin and gastrin levels and screen for symptoms related to MEN1. And, if there's any suspicion at all or any family history of primary hyperparathyroidism or kidney stones, then I'll send for genetic testing. And then it's just becoming easier and easier, at least at our institution, to get the genetic testing done. So I kind of have a low threshold for people under age 40 with primary hyperparathyroidism. Great. Well, thank you very much for these excellent questions. Keep them coming, and I'm going to go into the next case at this point. Oh, we have a summary. Nutrition for gastric bypass patients is important. As we mentioned, calcium citrate and often reasonably high doses of vitamin D. And, as we've discussed, bariatric surgery, specifically root gastric bypass, wouldn't even say may affect skeletal health, does affect skeletal health. And certainly we want to be thinking carefully about doing everything we can to optimize the bone health of these patients, especially, with the increasing incidence of obesity and the use of bariatric surgery to treat it. Okay. So now we're moving on to the second case. There are 3 total. So we've got plenty of time. So please interrupt if you have questions as we go through this. So this is a 76-year-old man who fell at the airport and sustained a hip fracture. When we see him in the hospital as part of our fracture liaison consult service. And speaking to him and review of systems, we note that in addition to this recent fall, over the past 1 or 2 years, he's noted this kind of proximal muscle weakness in the thighs and shoulders. His medications are listed here. He's on a thiazide for hypertension, and he had a prostate cancer that was treated with surgery about 4 years ago. Okay. So the only medication he's taking is the hydrochlorothiazide. On exam, it's unremarkable other than this proximal muscle weakness that we detect even in his shoulders after he had this hip fracture. And in addition to the hip fracture on imaging, it looks like there's kind of osteopenia throughout, at least on the x-rays that are obtained in the hospital. Okay, so here are his labs. He has a normal calcium. Unlike our previous patient, he has a normal PTH. Vitamin D level is okay at 39. And in his phosphate level is quite low. So our lab's normal reference range goes down to 2.5, and his comes back at 1.4. And this is repeated on fasting testing. Again, less, I think, at 1.5. So certainly hypophosphatemia is present. He has a 125 vitamin D level, which is sent off and eventually comes back at 33, which is on the lower side, especially in the setting of hypophosphatemia. And because of the hypophosphatemia, we obtain urine studies which show that his fractional excretion of phosphate is 25%, which is certainly high in the setting of hypophosphatemia. So because we may not be sending fractional phosphate excretion,
Most of them are. There's some
um,
Christian.
because we may not be sending fractional phosphate excretion measurements every day, to remind you all of the formula to calculate the fractional excretion of phosphate, which is listed here. So you measure the urine phosphate, the serum phosphate, and then the creatinine levels of those two fluids as well. This needs to be collected on a second void of the day, typically. And for a patient with hypophosphatemia, you expect the kidneys to be holding on to as much phosphate as possible. So you would expect to have a very low fractional excretion of phosphate. So if the fractional excretion of phosphate is greater than 10% in a patient with hypophosphatemia, that certainly indicates that there's urinary phosphate wasting present and kind of points us in a direction that isn't kind of so on the other hand, if the total body stores of phosphate are low in the setting of malnutrition or something like that, then the urinary phosphate excretion would be quite low. So this is indicating that the reason he has hypophosphatemia is inappropriate phosphaturia. Okay, so this is a little bit different than our typical patient on the fracture consult service who falls and has a hip fracture and all their labs are normal, and we say that this is kind of age-related osteoporosis. We've identified a potential secondary cause here in the hypophosphatemia. So now we need to kind of think a little bit more carefully about what's going on there. And so start thinking what diagnoses could be at play here to explain this hypophosphatemia with inappropriate phosphaturia. So in general, when hypophosphatemia is present, you worry about gut losses or internal redistribution or just reduced stores of whole body stores of phosphate. But here, because of the urine measurements, which are quite important, it really points us towards a potential renal etiology of inappropriate phosphate wasting. So to remind you all about how phosphate is kind of reabsorbed into the glomerular filtrate, or is excreted into the glomerular filtrate and then reabsorbed along the nephron, kind of remind you of what the nephron looks like. And, as the blood flows into the glomerulus, most of the phosphate is filtered out into the urinary filtrate and then is kind of reabsorbed in a regulated manner. And that reabsorption really happens primarily in the proximal tubule. So now what we're going to do is zoom in to the proximal tubule and review kind of how phosphate handling occurs. So now we're looking at an epithelial cell in the proximal tubule. This is a very big cell. And on top of the epithelial cell is the apical surface. So this is where the filtrate is present. And on the bottom is the basolateral surface. So this is where the blood flow is coming. And so to remind you, the phosphate is really reabsorbed in the proximal tubule by these very important transporters called sodium phosphate cotransporters, or NAPI sodium phosphate 2 transporters. And so these NAPI transporters, what they do is they bind to this phosphate, which is complexed with sodium in the glomerular filtrate, and reabsorb it into the cell. And then through a transcellular process, take that phosphate and pump it back into the blood. So in the setting of hypophosphatemia, these NAPI transporters should be very active. They should be really reabsorbing as much phosphate as possible from the urine to maintain the phosphate levels in the blood. However, the activity of these sodium phosphate cotransporters is hormonally regulated, like all things in the body, of course. And the hormonal regulation of NAPI activity is really primarily through the parathyroid hormone and FGF23. And what both PTH and FGF23 do is to block the activity of these NAPI transporters. And so when levels of either of these two hormones are high, what that does is it causes the NAPI protein to be internalized from the cell surface into these clathrin-coated pits. They go into the endocytic pathway, and the NAPI transporters are then degraded in the lysosomes. So when the NAPI transporters are no longer present on the cell surface, instead of being reabsorbed to the proximal tubule, the phosphate remains in the glomerular filtrate, and that's why you see the the increase in urinary phosphate levels. In addition to promoting the internalization of these NAPI transporters, PTH and FGF23 also turn off the expression of the genes that encode for these NAPI transporters. So it's kind of a double whammy. These hormones get rid of the protein on the surface, on the apical surface, and they turn off the further production of the protein itself. So when PTH and FGF23 levels are high, this really promotes urinary phosphate wasting. And that's why when we teach medical students about PTH, one of the things we say is it's stands for phosphate trashing hormone, or PTH. So again, the net effect is to leave the phosphate in the urinary space. All right, so moving along. Sorry, there's things happening in this chat. So now when we think about patients who have hypophosphatemia and inappropriate phosphaturia, which describes what we're seeing here in this man, we know that the chronic hypophosphatemia leads to undermineralization of bone, because phosphate is a critical component of bone, of the hydroxyapatite that's present. And so when you see hypophosphatemia with inappropriate phosphaturia, that starts letting you think about a certain group of diagnoses, which are listed here. Of course, you could have like a Fanconi syndrome, a general proximal tubulopathy, where hypophosphatemia is present. This can be medication-induced, this can be congenital, or these could be due to actually mutations in the NAPI transporters themselves. Usually these patients with Fanconi syndrome or generalized proximal tubulopathy will have loss of other substances in the urine, like glucose and amino acids, or on medications like tenofovir and other things like that that are known to interfere with the general function of the proximal tubule. In contrast, you can have long-standing excess in PTH, dramatic secondary hyperparathyroidism, or excess in FGF23. And I think FGF23 is key to this case, because we already know that the PTH levels are normal and there are no other features to suggest a Fanconi syndrome. So let's talk for a minute about FGF23 again before we come back to the patient. So FGF23 is a little bit complicated. The way I like to think about FGF23 is that it really lives to block the effects of vitamin D. So let me kind of talk through how I think about FGF23 physiology. And it really starts with calcium, right? It's very important for our cardiomyocytes and our neurons to maintain normal calcium levels. So when calcium starts to drop, the parathyroid gland senses that and releases parathyroid hormone. PTH then acts in its target organs to maintain normal calcemia. In bone, it promotes bone resorption. In the distal tubule, it promotes calcium reabsorption. And in the proximal tubule, PTH promotes the formation of 125 vitamin D. And 125 vitamin D is very potent at promoting the absorption of calcium from the gut and causing bone to release some calcium. And so once you make 125D, you need to kind of have a good way of regulating it. You need to have kind of a really potent counter-regulatory mechanism for 125 vitamin D. And that's kind of why I think FGF23 evolved, to really block the actions of 125 vitamin D. So FGF23 comes from bone and it circulates into the blood and acts on the kidney. So this is kind of cool, because by producing FGF23, the bone actually becomes an endocrine gland, in addition to a very important structure that responds to endocrine hormones. In the presence of 125 vitamin D, bone cells start making more FGF23, and FGF23 then goes to the kidney to promote phosphate or to block NaPi2A action and block phosphate reabsorption. This is important because 125 vitamin D promotes phosphate absorption from the gut. So you want to kind of start to get rid of some of that phosphate that you've absorbed, as long as you've absorbed enough of it. But in addition, FGF23 blocks 125 vitamin D. FGF23 turns on the 24 hydroxylase for vitamin D and turns off the 1 alpha hydroxylase. So this is a really potent way of quickly getting rid of that extra 125 that you've made. So this is kind of a little bit complicated because FGF23 has some actions that are like PTH. With respect to phosphate handling, they really do the same thing. But unlike PTH, FGF23 is blocking 125. And that seems to be a very important thing that it's doing. And, when we go back and look at the labs that our patient had, his phosphate is low and his 125 is low. So whenever you see that pattern of labs, hypophosphatemia, inappropriate phosphaturia, and low 125D, that really points to a condition where there's too much FGF23. So as I mentioned, FGF23 secretion is stimulated by dietary phosphate, by 125 vitamin D, and as many of you may know, in the setting of kidney failure, FGF23 levels are quite high. However, there can be some instances where FGF23 is too high for kind of pathologic reasons, not secondary reasons, and those conditions are listed here. So there are congenital forms of FGF23 excess and acquired forms of FGF23 excess. So I think in our patient, because this is a 76-year-old man who really didn't have problems with hypophosphatemia 10 years ago when we tracked down his previous labs, I think that really points to an acquired form of FGF23 excess, such as TIO, or tumor-induced osteomalacia. So in tumor-induced osteomalacia, the problem is that you have a tumor that's producing too much FGF23. Often these tumors can be very difficult to localize. They can be kind of hidden in the skin or in the kind of muscle sheaths or in tendon sheaths. So kind of once you kind of determine that TIO is the likely diagnosis, really the hunt is on to try to identify, to localize that tumor and remove it ideally. But often it can be quite challenging, and advanced imaging methods like PET, octreotide scans, or even like an interventional radiology-based venous sampling study, it can be very helpful in pointing towards the potential source of FGF23 in TIO. So traditionally, the treatment for TIO has been to try to find the tumor and to remove it. And if that isn't possible, and often it isn't because these tumors really hide away, then to use kind of the typical treatment regimen for hypophosphatemia, which is phosphate supplementation along with calcitriol. However, that regimen often is not well tolerated. Many patients develop GI disturbances with high-dose phosphate supplementation, and it is certainly possible to precipitate nephrocalcinosis or even nephrolithiasis with the combination of phosphate and calcitriol supplementation. So it's been very exciting in the past few years to see the development of these anti-FGF23 antibodies like burosumab for a number of diseases associated with FGF23 excess. And this really studies looking at burosumab efficacy in TIO patients led the FDA actually to approve this treatment for patients with TIO just a couple of years ago. So this is really an exciting development. Obviously, these are very rare patients, but in the experience that I've seen over the past few years, it has been necessary for a few of them to use burosumab because of the inability to localize the tumor. So to summarize what we covered in this case, when you have a patient with, a fragility fracture, the most important lesson is we want to be as careful as we possibly can to exclude secondary causes of bone fragility before we kind of make a diagnosis of osteoporosis and use anti-resorptive medications. Often this evaluation for secondary causes of osteoporosis, is unrevealing, but we really do want to make sure we've excluded hyperthyroidism, hyperparathyroidism, vitamin D deficiency, hypophosphatemia, other forms of hypercalcemia, kind of the common secondary causes of osteoporosis. And in this instance, that evaluation certainly was productive. And so once you see hypophosphatemia, the urine analysis to measure the fractional excretion of phosphate can be quite helpful. And along with that, looking at 125 vitamin D levels can be quite helpful, because if 125 D levels are low, that really does point you towards a condition of FGF23 excess. FGF23 is a bone-derived hormone that regulates phosphate and vitamin D metabolism in the kidney. Abnormal FGF23 levels can be due to either acquired like TIO, or congenital causes. And in addition to phosphate and 125 supplementation, now other treatment options are available, like burosumab, to block the excess in 125 vitamin D. Okay. So I think that's everything that we wanted to say, or that I wanted to say about certainly, if there are any questions, feel free to put them into the Q&A portion about this case, or any other patients that you might have with hypophosphatemia. Great. Okay. Well, if there aren't any questions, I certainly will move on to the final case. Let me just look. I think there's something in the chat. Okay, so somebody put a question into the chat, which says, our nephrologists always sends a consult to evaluate for primary hyperparathyroidism when calcium and phosphorus is normal. Can you guide me onto how to approach the situation to rule out normal calcemic primary hyperparathyroidism? I think that's a really fantastic question. It's a little bit funny for a nephrologist to be asking that question, because of course chronic kidney disease is a cause of secondary hyperparathyroidism. So I think that perhaps kind of some education for the nephrologist can be quite helpful. But I think in patients with mild kidney disease, this is an important thing. And I think my general take on evaluating for normal calcemic primary hyperparathyroidism is that patients with that entity typically have calcium levels that are right at the top of the normal range. So calcium levels are not like 8.9 or 9.1. They're kind of 10.3, 10.4, right at that right at the top. And then the urine calcium is really key in those individuals. So because you're really looking for evidence of excessive parathyroid hormone action and excessive bone resorption. So, for patients who have normal calcemic primary hyperparathyroidism, I think it's ruled out by hypocalciuria. So if you do that 24-hour urine collection and the urine calcium levels are less than 125 or so, you're pretty sure that's not normal calcemic primary hyperparathyroidism. If the urine calcium levels are really high, like over 300, then that points you in the right direction. So, in my experience, it's kind of that combination of looking carefully at the blood calcium level and saying it really has to be very close to elevated at the very upper end of the normal range. And, you want to see hypercalciuria, or at least the absence of hypocalciuria. I would not use imaging to, to look into this, because as you all know, the neck imaging is notoriously kind of non-specific. If you tell a radiologist to look for a parathyroid adenoma, often, they may see a lymph node and say, oh, that could be a candidate parathyroid adenoma. And often there can be real parathyroid adenomas that don't show up on any kind of imaging test, even like the 4D CT. So I would, emphasize the fact that this distinction and this diagnosis really should be made based on imaging, based on blood and urine tests. This is a biochemical diagnosis, not a radiographic. And, seeing kind of a candidate parathyroid adenoma on any kind of imaging study doesn't necessarily mean that that this patient, who clearly looks like they have secondary hyperparathyroidism, actually should be treated or considered as primary hyperparathyroidism or normal calcemic primary hyperparathyroidism. Okay, great. the follow-up question here, and actually, I would request that you guys put your questions into the Q&A rather than the chat. I can see both, but I think these direct messages to me in the chat aren't, showing up to everybody in the Q&A, and I think technically we're supposed to be using the Q&A. I don't care, but just a gentle request. So the follow-up question here is, does the answer apply if the urine volume is low on a CKD patient? Again, if the CKD is so bad that the urine volume is low, then that's the cause of the hyperparathyroidism. It's not, and often it can be challenging to measure urine calcium levels in patients with CKD because they're on thiazides or loop diuretics, which are going to have different effects on urine calcium. So, I think you have to remind your nephrologist that advanced CKD is a cause of secondary hyperparathyroidism. Okay, so another question came into the chat. Let me see if I put it into the Q&A so everybody can read it. I don't think I can add things to the Q&A because my job is to respond to them. Okay, so this says it's a 70-year-old woman with hypercalcemia for 10 years. PTH ranges between 16 and 31. PTHRP and 125 vitamin D are normal. She has breast cancer in remission and osteoporosis with a very low T-score in the forearm. There are no osseous lesions on CT. Any recommendations? Is this consistent with primary hyperparathyroidism? This is a tough one. So just to summarize for everybody, because I don't think you see this page. Oh, no, you do. It's now in the Q&A, the final question from the anonymous participant. So this is hypercalcemia, mild hypercalcemia with PTH levels between 16 and 31. So we teach everybody that in PTH-independent hypercalcemia, PTH should be suppressed. And in PTH-dependent hypercalcemia, PTH should not be suppressed. So really the question is like, how suppressed is suppressed? And is this suppressed enough to say that this is PTH independent, or is this actually PTH dependent hypercalcemia? It depends a little bit on your lab here. In our lab, generally if the PTH levels are above 15, we say that definitely if they're above 20, then it looks like PTH dependent hypercalcemia. And for patients who have, PTH independent hypercalcemia, the PTH levels are almost always less than 15. We're right at that border here, but I'd say a PTH of 31 in the setting of hypercalcemia, that's not suppressed. And so this seems much more likely to be a PTH dependent process. And in that case, for an older patient with likely primary hyperparathyroidism and osteoporosis, you can think about medical management with the bisphosphonate versus surgical management, depending on the patient's preferences and the availability of a parathyroid surgeon who's experienced at your institution. But this is right at the border. You might also want to send the lab somewhere else to see if you send them off to a send-out lab or have them run again. You might be able to catch the patient with a PTH of 40 and kind of make you feel better because that 16 is kind of a tricky number, I agree. So maybe I would kind of look carefully at the trend, and if they're more often closer to 31 than 16, that would point me in one direction versus another. But you're right at the threshold here. Okay, so there are a couple additional questions. So I'll go over these two from Rebecca, both from Dr. Jeffers. The first says that we have a 89-year-old man with primary hyperparathyroidism who had parathyroidectomy about 10 years ago, osteoporosis and kidney stones prior to the parathyroidectomy, who now has hyperparathyroidism. GFR is 46, calcium is 10.2, albumin 4.1, urine calcium is 99, phosphorus is 3.9, and vitamin D is 46. Would you call this your normal calcemic primary hyperparathyroidism considering the history? Also considering secondary hyperparathyroidism giving low GFR and the 24-hour urine calcium. Do you think 125D would be helpful? I don't think this is normal calcemic primary hyperparathyroidism. I think that the urine calcium is really the key here, along with the GFR. I think we have, a patient with CKD, which is a good cause of secondary hyperparathyroidism. And, if this were normal calcemic primary hyperparathyroidism or like a recurrence of the parathyroid adenoma, I think that the urine calcium level would be much higher. I said already that if the urine calcium is less than 100 in a day, that really points you strongly away from normocalcemic primary hyperparathyroidism. So I guess unless the patient is on like a thiazide medication that would lower the urine calcium independently of like what's going on with the parathyroid gland, then I think this is quite unlikely to be a recurrence of the primary hyperparathyroidism and much more likely related to the CKD. The 125D, may be helpful, although I doubt that it's going to change management. Obviously, in the setting of CKD, the 125D may not be as high as you think it might be, but often kind of like exactly what the 125 should be in the setting of a high PTH versus what it is, we don't quite have a good enough handle on what to expect there. So I think that the urine calcium measurement, and of course the fact that the blood calcium is normal and we have CKD, points me strongly towards away from normal calcemic primary hyperpara for that patient. Let's see. The next question from Dr. Jeffers refers to a 65-year-old woman with hypophosphatasia and osteoporosis with a very low T-score on abaloparatide, planning to complete 2 years of therapy. Given that we typically want to follow up with a bisphosphonate to maintain gains in bone density, but they are contraindicated in hypophosphatasia, what would you do? Exactly. This is a very challenging case. Certainly I think the use of a bone anabolic medication is appropriate. It looks like her T-score is very low. And so I think things that you could think about would be more than 2 years of PTH, which now seems to be safe. I think if she really has adult onset hypophosphatasia, the use of alkaline phosphatase replacement therapy with aspartase probably would not be approved, is not approved by the FDA and probably not covered. But, you could kind of query carefully back in time and see if there were any childhood fractures or any reasons to think that she might have had kind of adolescent onset hypophosphatasia. And in that instance, perhaps the alkaline phosphatase replacement therapy might be something useful to do. But in general, I agree that bisphosphonates should be avoided in patients with hypophosphatasia. And perhaps so basically your options are to continue on anabolic therapy or to see if she might be a candidate for aspartase. Let's see. So I'm going to keep going through the Q&A before we go to the final case because we're okay with respect to time. So Dr. Kashyap asks, is there any role of or concern of the use of anti-resorptives in these patients versus anabolics? I'm not sure. The question is about TIO. So for TIO, I think that first you want to treat the underlying disorder. So either that's removing the tumor that has been detected, or is blocking FGF23 with burosumab. I'm not aware of data about the concurrent use of bone-acting agents in TIO patients, and I would try to keep things relatively simple and normalize the blood phosphate either through medical or surgical approaches. It's a really good question, and I don't have any experience, and I'm not aware of publications using osteoporosis therapies to treat bone disease in TIO rather than either calcium medical or surgical management of the hypophosphatemia. Others have suggested using a low dose. Yeah, I think I would hope that bringing up the phosphate would be the main thing to do. If the phosphate is normal on those medications, but the bone density is still not good, then perhaps a low dose bisphosphonate could be reasonable. That's a very interesting case. Okay, well, these are great questions. Keep them coming. And I'm gonna go on and go through the third case. Just checking the time. We're okay. So this is a 30-year-old woman who is in her second trimester. She's 20 weeks pregnant, and she's referred to us for hypercalcemia. She has symptoms which are listed here. She's nausea, fatigue, heartburn, constipation, polyuria, and at first glance, all of those symptoms could be related to being in the second trimester of pregnancy. But of course, in the setting of hypercalcemia, we have to think hard. This is the medical history. This is her second pregnancy. She did have hyperemesis in the first trimester, and importantly, her history is notable for multiple previous kidney stones. The last was about a clinical episode of nephrolithiasis was about 2 years ago. Her medications are listed here. She's taking some Tums, prenatal vitamins, and some Zofran. Sorry. Her family history is non-contributory. Her exam is listed here. She has a pulse of 124, which I understand is a bit higher than typical in the second trimester of pregnancy. She looks well, although she looks dry. You do note tachycardia, and her abdominal exam is consistent with her being in her second trimester. Okay, so her labs are shown here. Her creatinine is slightly high for the second trimester. Her CO2 is okay. Her calcium is high at 11.5. Her albumin is slightly low, but her ionized calcium is high as well. Her phosphorus is on the lower end of normal. PTH is 100, with the normal range going up to 60. Her 25 vitamin D is 20. She has a 24-hour urine calcium, which it comes back at 500 milligrams. Remember, we said over 300 is, certainly high, and her TSH is normal. So what do we think of her labs? Obviously, for a patient with hypercalcemia, the first thing to do is to measure PTH and decide is this PTH dependent or independent. Unlike the question that came up in the chat where the PTH levels were somewhat indeterminate, here they're not indeterminate. This is clearly PTH dependent hypercalcemia associated with previous nephrolithiasis and hypercalciuria. So to remind you all about calcium metabolism during pregnancy. So these are kind of changes in some of the key calciotropic factors as they occur during the different trimesters of a normal pregnancy. During normal pregnancy, the total blood calcium goes down a little bit as albumin goes down, but the ionized calcium is maintained perfectly normal. The phosphorus levels really don't change. And pregnancy is kind of one of the only times during normal physiology where PTH is not the main driver of the main controller of calcium metabolism. PTH levels actually drop quite a bit normally during pregnancy. And despite that, 125D goes up. So that 125D really goes up. Something very strange just happened. That 125D goes up because there's kind of extra placental production of PTHRP, and maybe even some placental production of 125D. So normally the main driver of 125D formation is PTH, but during pregnancy there's kind of a dramatic increase in 125D in a PTH independent manner, and this is one of the main things that's improving calcium reabsorption and facilitating calcium transport into the placenta in order to improve the mineralization of the fetal skeleton. So now going back to our patient and remembering kind of what we discussed about normal kind of pregnancy physiology, it's very clear here that this elevated PTH is quite abnormal, and this patient certainly has PTH-independent hypercalcemia. So in thinking here about management, we should start thinking a bit about what additional tests we want to order. And in addition to additional tests, we have this patient who is tachycardic with dramatic hypercalcemia and hypercalciuria, sitting in front of us. So we also want to be thinking about management. So before thinking about additional testing, let's think about management. So we have some options. We could suggest that she push fluids, and we keep a careful eye on her. We could start cinacalcet, the calcium mimetic. We could give IV fluids along with a loop diuretic. We could give IV fluids along with an anti-resorptive medication, or we could give IV fluids and refer the patient to an expert endocrine surgeon. So I don't know how to use the poll. I don't think we have a poll option enabled for this. So think to yourself about what you think the answer or the best management option should be. for a second. I would say that this patient is probably too ill to do, and I'm concerned enough about the hypercalcemia to that I don't like option A. Calsa is certainly not proven to be safe in the setting of pregnancy due to the important role of the calcium sensing receptor in fetal mineralization. We don't love loop diuretics for pregnant patients. And also don't love anti-resorptives for pregnant patients. So this really leaves us with the final answer, which I think is probably the right management move in this. Okay. Oh, wait, we went ahead. Okay, so now we should be thinking a little bit more about our management. And so she's 20 weeks pregnant, so she's in the second trimester. Would our recommendations change if she were in a different stage of the pregnancy? In general, we love surgery if needed, and obviously we have a very careful consideration of that, but we really try to time surgery for the second trimester if at all possible in these instances. During the first trimester, just general anesthesia poses a risk of spontaneous miscarriage and fetal complications. And likewise, in the third trimester, for fetal complications. And so, I think kind of a referral to an expert parathyroid surgeon during the second trimester would be certainly important and, high on our list of things to do. What if we don't do surgery or now? What if we aren't comfortable with surgery in the second trimester and we say, okay, clearly she has primary hyperparathyroidism, she is young, she's had kidney stones, eventually we should do surgery, but let's wait. Let's wait until after she delivers. Are there any risks of delaying the surgery? So first of all, would our recommendations change? I think the surgery in the first trimester, as I mentioned already, comes with a risk of miscarriage. In the third trimester, we worry about preterm labor, and of course, delaying surgery in the third trimester. We have this woman who has a urine calcium of 500 milligrams a day, who's previously had kidney stones, and so we really do worry about a hypercalcemic crisis or kidney stones for the mother. And what about delaying surgery? So risks to the mother are things we've already mentioned. And then, I think it's very important to think about what happens to the fetus due to maternal hypercalcemia. Hypercalcemia is going to, be sensed in the fetal circulation as well, and may suppress the development of the parathyroid gland and the secretion of parathyroid hormone by the parathyroid gland in the fetus. And so infants born to mothers with hypercalcemia can present with hypocalcemic crises due to hypoparathyroidism, at the time of birth. And we've had infants in our neonatal intensive care unit for that reason. And so severe neonatal hypocalcemia is certainly a risk that you worry about when you have maternal hypercalcemia. So hopefully this case, and so for this patient, the imaging test was ultrasound, which is obviously the preferred test during pregnancy. And that ultrasound showed a large candidate single gland parathyroid adenoma. And so she was referred to an expert parathyroid surgeon who, performed the parathyroidectomy at about 21 weeks, and she did very well. And so hopefully this case gave us a good example to review some of the typical calcium physiologic changes that occur during pregnancy. As we mentioned, the total blood calcium levels go down a tiny bit, but the ionized calcium levels stay the same. And because of this high 125D, typically urine calcium levels do go up a little bit in all women during pregnancy, but not nearly as much as what we saw here in this patient with hyperparathyroidism. Great. So I think that is everything that we wanted to discuss. So now what I'm going to do is stop my sharing. Just give me a minute to do that. And we can kind of go over some of the questions that came up in the chat because there's so many fantastic questions. And please keep them. Oh, so Dr. Kawash asks a really important question about the pregnant woman about her thyroid function tests. And that should have been included on the slides, but thankfully her TFTs were normal. There's a really good question in the chat, not in the Q&A, from Dr. Rod Ruby about guidelines for dental implants and grafts in patients on denosumab. What do we tell the oral surgeons? So this is a very challenging question, and obviously a clinical topic that comes up over and over again in our older patients on these on anti-resorptive medications who frequently have dental complications that require either extractions or invasive dental work. So I think the first thing to emphasize, and this really isn't implied by the question, but just as a general point, is that the uh, dental complications for patients on anti-resorptives are related to the duration of therapy. So, very, very rare to develop osteonecrosis of the jaw or other major dental complications for patients on anti-resorptives for less than 5 years. The incidence of dental complications really is primarily seen in individuals who have existing dental disease. So, it's very rare to see jaw necrosis or other major dental complications for patients without pre-existing dental problems with dentition. So this is why I'm always kind of reassuring patients and making sure that they're seeing dentists on a regular basis, having things taken care of when they need to be, and preempting major problems before they arise. And I think the other thing is that to kind of be very clear with our patients before they get to the oral surgeon about what dental procedures to worry about and which dental procedures we need to worry much less about. So I think that for it's really the invasive dental procedures that involve the bone that where we worry about osteoporosis of the jaw for patients on long-term anti-resorptive therapies. And so that's extractions, implants, which require osseointegration, things that involve, so things that we don't need to worry about, kind of routine cavities, crowns, routine dental cleanings, periodontal disease. So there's a lot of very common dental work that's done where, we really need to worry. It's these invasive procedures that involve the mandible or maxilla. I haven't yet answered the question about implants because implants certainly are invasive dental work that involve the underlying bone. The concern here, I think, is that anti-resorptive therapies may interfere with the osseointegration of the dental implants. And there is some data from animal studies suggesting that that's the case. It's been very challenging, I think, to get high quality clinical data, about, osseointegration failure in the setting of anti-resorptive use. I worry much more about osseointegration failure than I do about osteonecrosis. It's really the extractions where you worry about osteonecrosis because that's where there's like an infection. For the implants, you don't want these patients to have to go through these complicated, painful, and expensive, procedures where implants are placed, and then to have a failure of osseointegration. Um, so I think for patients on denosumab, it's also a little bit tricky because we don't want to totally stop the denosumab because we know that when denosumab is stopped, there's a risk of rebound bone loss with spontaneous vertebral fractures. So, generally for patients on denosumab, I try to, time these things such that, you're not doing any invasive dental work within the 3 months or so after the denosumab. And it's kind of that second half of every 6 month treatment window where, we try to go. And, I think because there probably is some slight wearing off of the potent suppressive anti-resorptive effect of denosumab, and, to provide some reassurance to the oral surgeon that, if we use this timing, we're kind of doing everything that we possibly can. And, then I think it's kind of, if the oral surgeon comes back and says, I really need this patient off the medication completely, then it's kind of a conversation with the oral surgeon and the patient about kind of balancing the risk of potential rebound bone loss with the risk with what the surgeon may be concerned about osseointegration failure. So certainly a challenging topic. We spent a lot of time talking to our patients about these issues, and I wish there was kind of an easy answer. This is kind of one of the reasons that I don't love denosumab, because, unlike a bisphosphonate where you kind of have this slow wear off, and once you're kind of 6 months out from a dose of an IV bisphosphonate, we feel like things are probably okay to go ahead with invasive dental work. We don't really have that luxury of spacing out our denosumab injections quite so much. So hopefully I gave some answer. And, I've just found tremendous variation with respect to the oral surgeons that I speak with. Some are totally comfortable, and others, don't want to go anywhere near patients. So sometimes, it may be helpful to develop relationships with the different oral surgeons in your community and understand, which are more or less comfortable than others. But, in my experience, I haven't seen, huge problems with osseointegration failure due to anti-resorptive use, especially for patients who've been on these anti-resorptive medications for less than 5 years. So hopefully that answer a long-winded answer to a very challenging question. Another question that I see in the chat is from Dr. Kashyap, who asks about our patient, our third case, and whether she might need genetic testing. I think that's a fantastic question. And yes, I think the short answer is absolutely. For a 30-year-old woman with primary hyperparathyroidism, after the baby is delivered and she recovers from the surgery, I would start with checking, going over again the family history very carefully, checking prolactin and gastrin levels at the appropriate time, after pregnancy and she's done with her breastfeeding and off of any proton pump inhibitors, and, having a very low threshold to send for genetic testing. And there was another question in the chat earlier about what genetic testing to send. And, I think MEN1 is kind of the most obvious. There are, gene mutations that are associated with MEN2A and MEN4. I think our genetic counselors are quite good at kind of doing things in a stepwise manner and sending MEN1 testing when appropriate. I'm certainly happy we made it through the content that we were hoping to. I really appreciate the fantastic questions that have come up. What I'll do is I'll put my email into the chat in case there are any other questions that people want to reach out about. Oh, there's one more question from Dr. Kashyap, and then in the meantime, I'll put my email into the chat. So if you have other questions, you can certainly always reach out to me. So that's there. So Dr. Kashyap asks, CKD patient, if we want to take off denosumab with concern of hypocalcemia, what do we use as chaser therapy? And then asks about raloxifene. So this is a tricky one too. As you're alluding to, stopping denosumab is associated with rebound bone loss, but of course, now we have a black box warning about denosumab causing hypocalcemia in CKD. It seems like the hypocalcemia caused by denosumab in CKD happens like early in the course of therapy. So if you have patients who have done okay with 5 or 6 or 7 or 8 doses of denosumab without hypocalcemia afterwards. And in our practice, we typically will check calcium level 1 or 2 weeks after denosumab for all of our patients with CKD4 and above, not necessarily for maybe CKD3B. That's a bit at the discretion of the provider. But of course, we don't want to continue denosumab forever in most in most of our patients, even our individuals with CKD. So how do we kind of consolidate the gains in bone density and prevent bone resorption with stopping denosumab? In our non-CKD patients, zoledronic acid or potent bisphosphonates are great. In the setting of CKD, certainly pamidronate is an option. That's an IV bisphosphonate, which is seems to be much safer even for patients with who are on, with CKD4 or 5. So that's something that I'll use not infrequently. I don't love raloxifene in this patient population just because of the risk of venous thromboembolism. And, typically patients with CKD have other, comorbidities like hypertension, diabetes, advanced stage where you would worry about blood clots. And so, I don't think I've used raloxifene all that frequently. So usually it's either pamidronate, abandronate is also a bisphosphonate that seems to be relatively safe, or you could, use a milligram of zoledronic acid infused over an hour or something like that. But, those are the typical options. And then we'll check another, monitor the CTX levels as best we can. So check the CTX levels while they're on denosumab, and then typically kind of 2 months or so after the anti-resorptive therapy, and every few months thereafter. So this is a really challenging clinical question. I don't think we have great data to guide those management decisions. But what I mentioned, thinking strongly about pamidronate and abandronate or dose-reduced zoledronic acid as kind of the most kidney-friendly bisphosphonates, I think is reasonable. Okay, great. Well, again, thank you all so much for your participation and fantastic questions. I always enjoy doing the sessions for that purpose. And as I mentioned, my email is in the chat, so feel free to reach out offline if there are any other questions. And I hope you all enjoy the CME course and have a really wonderful rest of your day. Take care.